Good morning. What an incredibly well-behaved audience. Magically know when to stop. Thank you so much. Good morning, everyone. My name's Stephen Drew. I'm the CEO of Hepatitis New South Wales, and it's my very great pleasure to be here this morning and to be your MC. Fortunately, you don't have to put up with me for very long. I'll just get us started and then the real acts are on. Before we start, I'd like to acknowledge the traditional custodians of the land that we are meeting on here today, the Bidjigal people. I pay my respects to elders past and present, and I extend that respect to all Aboriginal and Torres Strait Islander people here today. Thank you all for coming and welcome to the Kirby Institute seminar series. And today's event is the Hepatitis C Elimination Progress in New South Wales, Successes and Future Challenges. Before we start, just want to do a bit of housekeeping. To start off with, the format for the seminar today, we'll start off with presentations. There'll be 3 presentations, and then we will have question and answers at the end. So after all of the presentations are finished, so you'll have to control your excitement and save those questions for the very end. Now, for those people online, you can interact by typing your questions throughout the talk. To ask a question, click on the icon with the speech bubble and a question mark in the top right-hand corner, and to open the Q&A chat screen. When you click on add a question, please remember to write your name. That would be really helpful so we can acknowledge you and you know that your question is up. This will help us reference your question and make answering easier. You can also upvote any questions you would like to be answered. So this is for everyone participating. You can also change the order of questions by clicking on the tab on the top right of the Q&A chat, which says most recent, and changing it to most liked. So that was easy. One thing I will also comment, workplace health and safety. Also, if there is an alarm or an emergency, please listen for the appropriate sounds and follow the instructions of staff who will take us all, hopefully, to safety, because they're here most often. We will get straight into it now. Our very first speaker is Scientia Professor Greg Dorr. He really does need no introduction, and he was quite adamant that I shouldn't, but there are people online who may have been hiding under a rock and not know him. So I will keep it short and sweet. Unfortunately, I'm sure Greg actually wrote this because it is very short and sweet. Greg Dorr is the Program Head of Viral Hepatitis Clinical Research Program at the Kirby Institute here at the University of New South Wales, Sydney. He is also an infectious diseases physician at St Vincent's Hospital here in Sydney, Australia. Ladies and gentlemen, please welcome Greg Dorr.
Well, thanks very much, Stephen, and thanks everyone for attending. Firstly, I'd also like to acknowledge the Bidjigal people, the lands at which I have been working on for many years, and pay my respects to elders past and present. This is a presentation of the key sort of findings from the second Hepatitis C Elimination in New South Wales Monitoring and Evaluation report. The first report was in 2019, and we had planned to do a report every second year. It's a little thing called a pandemic got in the way of that, but we're hopefully back on track, and hopefully we'll continue to monitor things closely, because this is a really crucial next 6 or 7 years for the response to hepatitis C. Firstly, I'd just like to acknowledge the team at the Kirby, particularly Marion Barrault, who's done an enormous amount of work putting this together, the report, and helping with the presentation. Also, I'd like to acknowledge Heather Valerio and Shane Tilakaratna, who've been sort of pivotal to bringing all the data together. The sort of, I suppose, the foundation for the report and monitoring hepatitis C is that there's a New South Wales hepatitis C strategy. We're in the middle of that 2022-2025 strategy. There's also Australia's 6th National Hepatitis C strategy that's out in sort of draft form at the moment, but will be released very shortly. It covers 2023 to 2030. And then there's a global health sector strategy with the WHO elimination targets embedded within that, and that's 2022 to 2030. I'm not going to go through all the sort of key targets, but just to sort of highlight that they are somewhat different. So, for For example, if we focus on reducing incidence of new infections, you can see that New South Wales strategy has a sort of relative reduction over the period of the strategy. The national strategy and the WHO sort of targets are coming into alignment. For example, in 2030, the target is to get the number of new infections down below 5 per 100,000 total population. And there's some interim targets there as well. What I wanted to do is go through not all the sort of data that's in the report, but some really key sort of findings in each section. So we'll start with, really importantly, primary prevention and harm reduction. This is our estimate of the number of needle and syringe distributions per person who injects drugs in New South Wales over the period from 2013. It's interesting that the WHO target for this measure is 300 needle and syringes distributed per injector per year. So Australia and New South Wales have been above that target for the last sort of decade and probably longer than that. So we can tick that target off. It doesn't mean that we can't improve things in terms of coverage and reducing needle sharing, but we can, I think, be quite proud that Australia has been really internationally leading in terms of this aspect. If you then look at data in terms of the proportion of people who inject who report sharing, needle syringe sharing over the previous month, it's been pretty stable over the last sort of 7 or 8 years. So around about that sort of 17 to sort of 20% mark. So that's a significant proportion of people who do report needle syringe sharing. Clearly that proportion, this is community-based data, clearly that proportion will be higher in correctional sort of settings, and I'm sure we'll sort of talk about that later on. What about data on opioid agonist therapy uptake? So this is data that we get from New South Wales Health, and it gives us information on the number of people receiving OAT on a census day, which is, I think, the end of June every year. There's a census sort of date, and we get an estimate of the number of people receiving OAT. You can see this encouraging increase over the last sort of decade, and increase both in terms of number of people in the community and, more importantly, the marked increase in the number of people in the correctional setting that are receiving OAT, more than a doubling over the period from 2015 to 2023. If we look at the type of OAT, you can see that the proportion of total OAT that is methadone has reduced somewhat over the last sort of several years, and I'll talk about that, why that might be. You can see increasing proportion of buprenorphine. So that's in community settings. It's really quite marked, the data from correctional settings. You can see this very large increase in the number of people receiving buprenorphine, particularly since 2019, and obviously specifically related to the availability of depot buprenorphine and the real wish to expand access through scaling up depot buprenorphine in correctional settings. Moving on to hepatitis C testing and diagnosis. This is data from OzHep. That's a prison surveillance project that is led at the Kirby by Andrew Lloyd and Behzad Jari-Sadeh. And this is information on hepatitis C testing among OzHep participants with a history of injecting drug use. So this is self-reported information on ever hepatitis C testing. You can see the vast majority of people report testing, and most of that testing has been done in the prison sort of setting, obviously some in the community and some having had testing in both settings. This is data that I think is increasingly important. So even though we've done pretty well in terms of the proportion of people diagnosed, there is a significant minority of people that have what we describe as late hepatitis C diagnosis. So that's categorized as people who present to hospital with liver failure or liver cancer, so decompensated cirrhosis or hepatocellular carcinoma, and have only been diagnosed with their hepatitis within 2 years prior to that hospital admission. So we see this as a missed opportunity. So many of these people may not have had time to have effective intervention to prevent that advanced liver disease complication. Now, there's some sort of improvement. So from 2015 to 2018, and we get this data from our data linkage project, it's reduced from 19% to 16%. But a couple of the factors here, there's a little bit of a difference in gender. The older age group tend to have a lower late diagnosis than the younger age groups. The overseas born members of the community have a somewhat higher, but not markedly high rate of late diagnosis. But what we found was the key sort of area of sort of diversity in terms of late diagnosis proportion was when we looked at it by geographical area of residence. So people that are residing in the rural areas, 22% of people presenting with liver failure or liver cancer are only diagnosed with hepatitis C very late. And that's twice as high as the metropolitan areas. So 22% rural, 16% outer metropolitan, and 11% in the metropolitan area. So really some work to do there in terms of trying to lift diagnosis in rural areas and prevent these advanced liver disease complications. What about treatment? I just wanted to go through how we're estimating treatment coverage, because there's been some differences in how people have tried to work out what's the treatment coverage. So if you think of a high-risk population, a population, say, of people who inject drugs, there's a proportion of people that have never been infected, relatively small proportion. Then you've got a proportion of people who have been infected but have spontaneously cleared the virus. And then people that have chronic infection, most of those, thankfully, now have received treatment. And then you've got a proportion of people who are RNA positive, obviously some having received treatment and either developed treatment failure or reinfection, and some people who are RNA positive, so have current infection, but have never been treated. So in terms of the people that we're interested in terms of the treatment eligible population, those are clearly people that have been treated. So assuming that they were eligible at the time they received treatment, I think that's a reasonable assumption. They're included in the denominator, and people that have current infection. Now, there may be a few people that have acute current infection rather than progressed to chronic infection, but that's going to be a relatively small number of people. So that's our denominator for treatment eligible. And then we look at the uptake. So the participants that have ever received hepatitis C treatment among this denominator population. And in this example, it's 85% uptake because the proportion of people that are eligible was 65 and 55% have received therapy. So that's how we've gone about, determining our treatment coverage. So we looked at this in a number of different studies. And the news is pretty encouraging. So you can see data from the Needle and Syringe Program survey, from the OzHep Prison survey, from Ethos Engage, a community-based observational cohort, the National Program Point of Care Testing Project, and Search 3X, which is a project of hepatitis C screening in emergency departments. In the period 2022 to 2024, in those studies that we've got data, all above 80%. Now, the WHO target is to treat 80% of people diagnosed. So some of these studies are actually 80% of all people eligible, including proportion of people that are undiagnosed. So we're doing pretty well in terms of what the WHO target is. Let's look specifically at some of these studies in a bit more detail. So this is Ethos Engage. So this is an observational cohort that recruits people through drug treatment and NSP sites. It's a national study, but we're focused on data from New South Wales, obviously, for the report. And you can see the treatment sort of coverage increasing through the 3 waves of Ethos Engage. So the first wave being in 2018, 2019, 68% overall treatment coverage, increasing to 81%, 2019, 2021, and further increasing to 89% in 2023. So really quite impressive treatment coverage. We were a bit worried about women having a lower treatment sort of coverage, but they're sort of catching up. So it's not far behind the male treatment coverage in the most recent sort of period. We're a bit worried about younger people. Would they get the sort of treatment coverage that the older sort of cohorts were getting? And you can see the equity across by age. We're also clearly concerned about whether we were getting good treatment coverage in Aboriginal and Torres Strait Islander peoples within New South Wales. And you can see this data demonstrating equity compared to non-Indigenous population. What's an interesting finding is that of all the sort of characteristics, there is somewhat lower treatment uptake in people whose major drug injected is opioids. And I'll show you some further sort of data a bit later on that sort of bears that out in other studies. What about overall treatment numbers in the community and the prison sort of setting? And this data comes from New South Wales Health. And you can see 2023 was the first year since the DA era where we saw an increase compared to the last year. Now you might say, well, it was declining pretty sort of rapidly. We had to get a bounce at some stage, but I think it was very encouraging that we saw this increasing number of people initiating treatment. So this is initial therapy. And you can see that the increase was both in the community numbers as well as the numbers through Justice Health, so in correctional settings. What about the number of retreatments? So clearly people can be retreated for treatment failure or for reinfection. I'll show you some data that divides those two sort of categories. This is the total number of retreatments, so it's higher than the number of individuals retreated because some people get a second and a third sort of retreatment course. But again, this encouraging, well, I think it's encouraging. Some people are concerned about this in terms of the incidence of reinfection, but I think it's actually encouraging that we are detecting cases of reinfection. We're getting those people onto treatment, both in the community setting and particularly this increase in the Justice Health setting, where about 40% of all retreatments are through Justice Health. Okay, what about data specifically within the prison setting? So this is data again from the OzHep prison surveillance system, and you can see that the proportion of people who are eligible that have ever been treated, 84%. And most of that treatment being delivered in the prison setting. So clearly some people have been treated in the community, some people have been treated in both sort of settings, but the large majority of those people who've ever received therapy being treated in the prison setting. This is the overall trends in terms of the number of people initiating therapy since 2016 when we had PBS listing with the DA therapies and the number of people being retreated. And I just wanted to go through this in a little bit more detail. And this is data based on a project called PHASE. It's led by Joanne Carson, a postdoc in our program who has a mathematical modeling algorithm that sorts people into people that are likely to have been retreated for a treatment failure and people that are likely to have been retreated for reinfection. So let's start with the trends in treatment failure retreatment. You can see this increase in 2019, which is when we got the first, what we call second line or salvage regimen that was licensed in the PBS, sofosbuvir, velpatasvir, voxeloprevir, and then a decline since then. And then you've got retreatment for reinfection with this sort of increase through to 2021, a bit of a dip in 2021, maybe related to the pandemic, and then this increase, particularly in the last year. That the solid line is the number of individuals that were retreated in each year, and the hash line is the total number of retreatment courses for reinfection retreatment, and that's just the total overall number. So as I said, I don't think this is necessarily a negative thing that we're seeing increasing retreatment for reinfection. I think it's part of the response to the pandemic, to the hepatitis C epidemic, that we really need to detect those cases and get them onto therapy. What about stigma and discrimination? I've showed you some pretty encouraging sort of news on several fronts so far. This is less encouraging. So we have data from Ethos Engage, where participants, people who inject drugs, are asked about negative experiences in the recent sort of period. I think it's the last 12 months. And they're asked about those experiences in relation to their injecting drug use and to their hepatitis C. And there's concerning proportions of people that experience discrimination and stigma related to injecting drug use and hepatitis C. Maybe you can see a slight sort of decrease in that related hepatitis C in the more recent period compared to the previous period, but still concerning proportions of people. This is data from the Stigma Indicators Monitoring Project that Carla Trelaw sort of leads, and this is sort of the flip side. So this is asking people from the general public and healthcare workers about their negative attitudes to people who inject drugs. So again, concerning attitudes related to injecting drug use from both the general public in terms of the proportion of people that always, often, or sometimes have negative sort of attitudes towards people who inject drugs, and also healthcare workers. I mean, less so than the general public, so that's some sort of encouragement, but still concerning levels of stigma and discrimination reflective in those surveys. Moving on to people living with hepatitis C. So this is, we showed you some data on treatment coverage obviously increasing treatment coverage and scaling up and curing lots of people, you would expect a reduction in the RNA prevalence, so the prevalence of current infection. So this is data from the NSP survey from 2015, the year before DA therapy became PBS listed, when around about a half of the people who inject drugs who are being surveyed through the needle syringe program survey with a dry blood spot sample and tested for RNA had active infection. And that those sort of high levels across all the key sort of demographic sort of characteristics. And this is a pretty amazing response. We've seen 2016, 2017, 2018, 2019, 2020, 2021, 2022. So this progressive decline in the proportion of participants that have active infection down to a level just below sort of 10%, and reasonable sort of equity across those key sort of demographic sort of characteristics. So look, another sort of indication of why we should be proud of the response in terms of providing pretty equitable access to these highly curative therapies for marginalized populations. Similar data from Ethos Engage in those three waves that I've talked about, from 2018, 2019, the first wave. And you can see this progressive decline in RNA prevalence to a level below 10%. Good reductions in women as well as men, low prevalence now in the younger age group, and also low prevalence, and in fact, slightly lower in Aboriginal and Torres Strait Islander sort of participants within Ethos Engage. So all of those measures being now less than 10%, but there's sort of one group I've talked about before. This is people who were the major drug injected, I think it's in the previous month, were opioids with a significantly lower prevalence of current infection in those injecting stimulants. So I think that's some data that we need to sort of explore a bit further to find out exactly what's behind that finding. What about prevalence of current infection in the prison setting? So this is OzHep data, specifically not in all the total prison population sampled, but in people that were surveyed that reported a history of injecting drug use. And there is a concerning sort of finding here within the prison setting through the OzHep sort of surveillance data that those that identified as Aboriginal and Torres Strait Islander had significantly higher prevalence of current infection within the sort of prison setting. So I think it was around about sort of 22%, the overall prevalence being 17%. So still, reflective of the work that we need to do, particularly in correctional settings, and particularly in people identifying as Aboriginal and Torres Strait Islander. We've been running a project called CEASE for several years. That's been led by Gail Matthews and Marianne Martinello, looking at the prevalence of hepatitis C in people with HIV. So initially people were enrolled who were antibody positive for both HIV and hepatitis C. And the large majority of those pre-DA therapy had current infection. Obviously some had spontaneously cleared the virus, but more than 85% had current infection. You can see this pretty amazing decline in current infection prevalence to less than 1% in the most recent sort of period that was surveyed through the CEASE. And to show you what happens when you get the current sort of infection prevalence down, you turn off the tap of transmission. So this is the estimated incidence of reinfection within the CEASE cohort, which was around about 4 per 100 person years, so a 4% annual risk back in the pre-DA era, down to basically 0. So we're just not seeing cases of new infections within people with HIV. And that's both reinfection and acute sort of new infection. We just do not see them very often at all. So really incredible sort of response within the population of people with HIV. Some more data around HIV incidence. This is mathematical modeling data that estimates the current hepatitis C incidence, which is around about halved over the period from 2016 to 2022, so 60% reduction over that period from 26 down to 11 per 100,000 population. So that's the 100,000 population, not 100,000 people with hepatitis C, but the 100,000 total population. And the relevance of that is the WHO target is to get that incidence down to less than 5 per 100,000 population. So you can see the dotted line sort of keeps going. I think that gets to about 2027. So we're sort of on track, I think, to reach that target, certainly before 2030, maybe a few years even earlier in New South Wales. This is younger age notifications. This is not necessarily new infections, but we use notifications in the younger age group as a surrogate of transmission, because most of these people would have been infected in the last sort of several years at least. So the trends in these notifications are important. And you can see this progressive decline in those notifications since the DA era. But what's been interesting is that there has been an uptick in the overall notifications in 2023. And if you look at those notifications, where that increase has been in Justice Health. Now, does that mean that there's been increased incidence of infection? I'm not sure. I think it's more reflective of increased screening in Justice Health, identifying those cases. So I don't think, again, I don't think that's a negative finding. I think it's probably a positive finding in terms of the activity in terms of Hep C screening in correctional settings. Moving on to morbidity and mortality. This is again data through our linkage project, where we link all Hep C notifications with a range of administrative data sets, including hospitalization. So these are people being admitted with liver failure, decompensated cirrhosis, and a really encouraging downward trend since 2015. These are numbers of people being admitted with hepatocellular carcinoma. Less impressive downward trend, and I think the reason for that is that many people with cirrhosis have been cured, but they remain at some risk of liver cancer, albeit a reduced risk because they're being cured of infection. We do see many cases of HCC in people that are being cured. So it'll take a bit longer to get that trend moving down more rapidly. And this is overall liver-related deaths, and it's now at 3.8 per 100,000 total population. This is the WHO target of less than 2 per 100,000 population liver-related deaths. So we've got a bit more work to do there to reach that target, and we can talk about maybe in the Q&A how we might do that. But there's several things I think we could really focus on. What about the overall cascade of care? This is mathematical modelling data, and we can see the number of people living with hepatitis C in New South Wales has halved from around about 60,000 to 30,000. Most of those people that are living with hepatitis C now have been diagnosed. About 3/4 have been RNA tested and confirmed with infection. And you can see the cumulative number of people treated over the DA era and the cumulative estimate of number of people cured. Some other cascade of care information I think is really, really important is the data coming through from Search 3X. And I mentioned that was a hepatitis screening project in emergency department setting. So there's been 3 of 6 emergency departments that have been involved in the project so far: Fairfield, Liverpool and Campbelltown, with 3 more, Canterbury, Bankstown and Dubbo, to come through over the next sort of 12 months. And what that does is it screens the large majority of people coming through emergency departments. We've found a bit over 300 people that Hep C antibody positive. The large majority of those, really encouraging, have had known hepatitis C. And then we've looked at the proportion that are treatment eligible and the proportion that have received therapy. So again, very encouraging diagnosis rates, not perfect, but encouraging, and very encouraging treatment sort of coverage. Still a proportion of people RNA positive, but of those that have had RNA testing, still some to be done or missing. But the large majority of those who've had RNA testing amongst the antibody positive are RNA negative, reflecting treatment-induced clearance and a bit of spontaneous clearance. So look, overall, I think the news is good. Lots of organisations have contributed data to the report and the presentation. Really thankful for everyone that's really sent the data in and worked with us over many sort of years. Not going to go through all the names, but we had a great sort of working group that guided development of this report, and really sort of appreciate the involvement of all members of the working group. And the report's now available on the Kirby website. So it'd be great if people could have a look at it. I think it sort of visually looks great, and it really is a great summary of how we're progressing in terms of Hep C in New South Wales. So thanks very much.
Thank you very much, Greg. Just a reminder, keep your questions to the end and make sure you've got that chat box open with your Q&As so that you don't forget them. We're just going to take a short break in this session, and it's my very great pleasure to introduce Aunty Lola, who will be doing a welcome to country. Please make Aunty Lola welcome.
Thank you. Sorry for being late. I'm an Aboriginal health worker and we had a little bit of a new baby crisis this morning. So, yeah, and I kind of lost track of time. But it has been resolved and the baby's fine. So, something that's good. Nagami Nagan Aunty Lola. Nagan Guli Darawal La Perouse. Nalamaning Bidjigal Gamamaringai Darawalanga. Welcome, I'm Aunty Lola and I'm a Darawal elder and I'm from La Perouse. And I acknowledge we're on the land of the Bidjigal and I introduce myself in our Darawal language. Our Darawal language is being brought back into our community through our Bidjigal Foundation, and that our language was lost when our people were put onto an Aboriginal reserve by the Aboriginal Protection Board many, many years ago. So I go on Monday nights to learn the language, my language that I never grew up speaking because it weren't allowed on the reserve. So, and it's not an easy language to learn. It's quite difficult, but I would like to learn it because my grandchildren are learning it in our schools and our preschools and our daycare centres. And personally, I don't want them to be teenagers and tell me off in Darawal and I won't know what they're saying. So, I've always wanted to learn my language anyway, but that might be a little bit towards the main reason. So I like to pay my respects to elders past, present and emerging and extend that respect to all of you here today. It's really a pleasure to be back at the Kirby Institute and welcome you all to your information day today. Our welcome is to ensure everyone feels welcome to the land and to thank our ancestors for taking care of our land, our oceans and our waterways, as they only took what they needed to survive. That way no families went hungry, and how we have survived over 65,000 years and live in such a beautiful country. And now being a multicultural country, it's great because we can still all look after the land and our oceans and our waterways, and we'll still be here for many hundreds of thousands of years forever. But we do have to take care of the environment. So our people seasonally walked the land from Sydney Harbour to the Shoalhaven region, and that was to sustain the food and the vegetation and the wildlife. And by doing that, there was always plenty of food as they moved around the land and as other tribes come behind them. So on behalf of my ancestors and my community, I wish you all a very warm welcome. As spiritual people, we believe our ancestors are always with us, so may their spirits be with you, keep you safe on your journeys, wherever they may take you now and into the future. Budji Nandawabi, thank you. Have a great day. And I do apologise for being late. Sorry. Thank you. Thank you.
Thank you so much, Aunty Lola, and very much appreciate your very warm welcome and the reminder of the ongoing connection that the Aboriginal people have with this land and the importance of language, as we're learning today, the importance of language and also local knowledge, which obviously applies today in terms of our knowledge of Hep C. And so thank you very much, and we will get on to the rest of the program. Greg spoke and highlighted some really interesting stuff around the Justice Health data. So it's nice and timely that our next speaker is indeed going to pursue some of that investigation a little bit further. So our next speaker is Collete McGrath, who is the General Manager of Population and Preventative Health with New South Wales Health. Collete has been a part of New South Wales Health since 1996. contributing her expertise and experience to the organisation for many years. In 2016, she joined Justice Health New South Wales, marking her involvement in this specialised sector. In recognition of her capabilities, Collete was appointed as the Interim General Manager for Populations and Preventative Health in June 2023. Her dedication to public health and her wealth of experience make her a valuable leader in advancing population health initiatives and preventative measures within the organisation. Collete will be presenting on the topic of justice health as a pivotal driver of hepatitis C elimination. Ladies and gentlemen, please welcome Collete McGrath.
Thanks, Stephen, and thanks very much to Aunty Lola as well. I'm really privileged to be invited today, and I guess just to say that unfortunately, it is also very sad that we have a massive overrepresentation of Aboriginal people in our prison system. Currently, I think it's over 31. It's well over 30% now for males, and much higher for women and young people. So that's something that we're really conscious of, and I think it's a massive opportunity that we have to try and make a difference here. You said, Stephen, that I joined in Justice Health in 2016. And those of you who probably don't know, is the reason I joined was actually because of hepatitis C. I was in a brilliant job in South Eastern Sydney as in the HARP unit, but I actually looked over at Justice Health and I thought that's where it's going to be. And unfortunately, I was right. But we'll keep trying. So look, I'll go through this fairly quickly. There's about 39 prisons in Justice Health, the correctional system. They change, they go up and down depending on movements, but that's currently, and we've currently got 3 privates. There's almost 13,000 patients at the moment in the public. Sorry, it's actually in total, 13,000 in total, not as well as. And about 30,000 people cycle through the system annually. So you can imagine that's really quick. And increasingly, we've now got more remand prisoners than we actually do sentenced. I think it's about 54% remand is where we're currently sitting. And the numbers are starting to grow again with the change in some of the laws more recently. The average amount of movements per year is about 4, but it can often be more. Sometimes we find patients who've been moved 15, 20 times across the state. So you can imagine, I thought it was going to be really easy when I first started there, but keeping track is not always as easy as you think. And as I said, unfortunately, we've got a mass overrepresentation of Aboriginal people in the system. And as I said, juvenile even higher. Our current positivity rate is now around 6 to 8%, which has decreased from about 13 to 15. Although when we do targeted testing, it's definitely higher, but that's usually when we do our high intensity campaigns in one big prison, so incorporating everybody. Just some numbers. This is the number of patients we've treated since the initiation. Sort of over 7,500. And last year we did 1,179. Still can't quite hit the target, but we did get a massive increase. We really dropped down during COVID because we're also the public health unit. And so that was one of the major reasons that honestly I had to be taken off the ball because we had to try and do a lot of other things. But we're back on track, I'm happy to say. And again, the estimated health costs avoided, pretty significant. In terms of testing modalities, like everybody, point of care, antibody testing, RNA, dried blood spot and venipuncture. And we have a variety of models of care. We do roaming, targeted testing. We have in situ machines, high intensity campaigns, some with health promotion, some without, self-referral in our early detection program. And we do it everywhere in the prisons where we can, basically in the health centres, in the yards, the pods, the cells, the wings, wherever we can get a patient to stop long enough really is really our aim. What are our elimination strategies? Obviously, I've mentioned we've got the rapid point of care RNA testing machines in situ in larger prisons, both male and female. We also have a roaming team of 2 nurses who conduct mass testing events across the state with support from staff on site. So generally running about 2 of those a month. And then we also have our high intensity campaigns, which includes a lot of harm reduction education and support in partnership with Hepatitis New South Wales and NUA. And we aim to do at least 3 of those a year. We also have the rapid point of care antibody testing, which we use in the mass testing and the high intensity events for all patients. And that's generally just mass testing for anybody who wants it. And we do obviously not get the same prevalence that we do when we do targeted, but you certainly pick up patients who actually had no idea, don't remember, didn't think that they had it. So it's still absolutely worth us doing, particularly in those late diagnoses, I think, at times. And then, of course, the rapid RNA testing is conducted The dry blood spot test has also been really useful for us, particularly in the early days, and hopefully when we can bring it into receptions once it gets licensed, in the sense that it's not a needle. It's not a big needle. We used to get a lot of opposition from corrective services about bringing a needle into the yards or areas where there wasn't enough supervision. And because that was just a finger prick, it was just so much easier. So that was a bit of a game changer for us. And also, of course, we reduced numerous Hep C resources and HCV patient experiences. And that's really to push demand from our patients. We've only recently, in the last couple of years, been able to get some video experiences onto the patient digital platform. That's very new. It was really pushed out by corrective services through COVID. Before that, we were reliant on paper and leaflets. Everybody else in the world is going to social media, TV campaigns. We were still very reliant on posters and paper and word of mouth, but we're slowly getting to change, which is way too late, but finally it's happening. So we're very happy with that. Other elimination strategies, as I say, we've introduced now rapid antibody testing for all of our patients who enter the drug court program. And the testing is now conducted by our drug and alcohol staff. It's a nice thing being in the one directorate. We can kind of work very closely together. And then the positive patients will receive the POCT RNA conducted by the POP Health team. We've now got 2 trained drug and alcohol nurse practitioners who are scaling up now, who are actually trained to be able to prescribe for hepatitis C. The second one's just completed. So it's very exciting, not having to rely just on the POP Health team or our POP Health doctor. So that's fantastic. And they've got a few more. I think they've got 3 other MPs. So I've got my eye on them as well. We'll see how we go. We have an Aboriginal chronic care team, and they're certainly now starting to become more engaged with us in terms of being able to do rapid antibody testing and the dry blood spot testing. Again, we don't necessarily see everybody, so we're trying to just get our fingers out as far as we can. We've piloted harm reduction hepatitis peer programs in 3 prisons now, because we know the importance of peers and getting that message out, particularly when there's issues around stigma and discrimination. And so that's been really successful. We've now got a really exciting program where we partnered with corrective services to roll out us educating peers in the prison. And they're actually going to get paid by corrective services and enhancement on their current wages to be peers in terms of harm reduction and encourage people. So that's hopefully starting this year. We're just in the kind of getting position descriptions ready and getting people to apply within the prison, which is fantastic. We've also got a hepatitis linkage to care, primary care program funded by the Primary Health Care Network. This can sometimes be a challenge for us. Patients leave often very quickly, sometimes without any address to go to. So just really trying to make sure we don't lose people if we've tested them, but we haven't managed to treat them. Again, particularly with people coming in and out very quickly in relation to remand. They can be there for a week or 2 weeks, sometimes longer, but sometimes really short. So again, something that we're really trying very hard not to lose people. We also have hepatitis C referral pathways for patients exiting custody with all LHDs across the state. So again, when we can link them in to make sure they're followed up, for follow-up treatment or needing retesting, just to make sure they have cleared. Hopefully we've treated most. And of course, we're part of the Kirby National HCV program, which is fantastic. And again, has been a really great support for us. Future strategies, obviously, we're just developing our own hepatitis C, the elimination program and strategy, which obviously will align with the ministries, but with a specific focus on people in custody. And also we will look at how we can increase the pilot of the rapid HCV antibody and the RNA testing, particularly at remand and reception centres. And then that will probably grow into more with the potential for the DBS once that's licensed as well. Although we're still using DBS in our mass testing programs in prisons as well. And we have a 3-year project to also address our HCV retreatment, particularly amongst our First Nations people. As I said, we've got a huge overrepresentation, and they're also where the biggest overrepresentation generally is of reinfections. Now that may be because they're rural. A lot of our patients come from rural areas. But also a lot of our Aboriginal patients anecdotally say things like, I waited till I come to prison to get treated. So they might know, but they know that they can get treated very easily. They don't have to travel in the same way. So we really try and target our Aboriginal population, and we do a lot of high intensity and roaming testing in our rural prisons, because that's often where there's higher percentages of our Aboriginal population. And thank you for the ministry for funding that and supporting us for the next 3 years. So we're really excited to work on that. We've also got a consumer advisory group being set up in and outside the prison to guide and inform Justice Health and that plan. I guess harm reduction is really important. One of the challenges, of course, is that we don't have an NSP. It's a prison. It's very difficult. It's a very difficult concept to introduce. But we're currently at least trying to get across the line, looking at sort of different types of disinfectant. We know that our patients find Fincol really, really hard to use. It's very complex and they don't use it correctly. And so corrective services are certainly open to us now looking at some other alternatives, and we're currently working with them to explore how that might work, and hopefully we'll get some traction on that. We're also looking at getting the development of our clinical applications to detail real-time HCV cascaded care. And that's something that's really important for us to always improve on, how fast we can do it, where we're failing, where are the points of failure, how can we improve? And so that's coming along well as well. And looking at also quick opt-out testing is fully integrated into a broader screening program and a comprehensive assessment for people in custody. We have our people who inject drugs continue to be engaged to identify ongoing health and stigma reduction needs and programs, and strengthen our outbreak response plan to quickly activate variant response interventions. Thankfully, we seldom pick up a major response, but sometimes we go to a prison and we'll pick up a slightly higher percentage and be like, what's happening there? We might find out there's a lot more drugs coming into that particular prison over a certain period of time. And so we might just have to switch our focus for a longer period of time on particular prisons based on what's going on. Obviously, drugs come into prison like anywhere else. And so it's really important for us to never take our eye off the ball in terms of what's happening. And also, of course, trying to conduct internal research on our HCV retreatments in custody, both qualitative and quantitative. And we wanted to continue to advocate for equity of care comparable to the community, which we're looking at. I won't go into much of this data really, because Greg, I think, has covered a lot of the Justice Health data, but you can just see, I would just will point out the years. You can see where we went down. That was absolutely COVID. I mean, it was COVID. There was no other reason. Our testing dropped, our treatment dropped, because, you know, most of the teams were basically focused on trying to keep COVID out of prison. So hopefully we don't get another one to interrupt us again. But it was a real challenge for us to maintain. So hand on heart, definitely COVID, but we're definitely coming back up. These are our retreatment figures. Again, you can see they're pretty big as the years go on, which, as Greg says, you can see that that's not necessarily a bad thing that happens, but we're catching a lot of people. And again, increasing, it went down again, that again, purely because of COVID during those years, because we just weren't testing enough. And then the retreatments, again, a lot of retreatments that we pick up in prison. Not all of those patients have been reinfected. Some are treatment failures. What we do know is that we've got 360 people that we've picked up that have definitely incurred while they're in custody. So they've never left custody. We've treated them, they've been cleared, and they've become reinfected. And so that's an ongoing issue for us. And again, a massive representation of our Indigenous population, which is, again, one of the reasons that we're really trying to focus on what that's about. And you can see there on the left-hand side, finally, just that there's the treatment numbers in terms of our Indigenous population continue to grow, and some people have been treated now up to 5 times, which is a major concern. I think that's all I've got, really. Just thank you, everybody, for inviting me. And again, thank you for all the support we get in Justice Health, because when I came there, it was like, how hard can it be? Everybody's in the one place, but it's a lot harder than I expected. But I think, you know, it's still a real area of focus that we need to keep going on. And we're getting a lot of support from everybody in the States. So thank you very much.
Thank you, Collette. Some very interesting information there. And I'm sure you'll have lots of questions. So again, a plug. Don't forget to put your questions into the Q&A chat, and don't forget to upvote for those questions that may already be there. We have a third and final speaker before we go to questions, and it's someone who I think is very well known to all of us, or many of us here. Dr. Kerry Chand is the Chief Health Officer of New South Wales Health, is a public health physician who has been Chief Health Officer in New South Wales since 2008. She gained prominence during that period that shall not be named, providing regular public health advice for New South Wales, a contribution for which she was named the State's Woman of the Year in March 2021. Ladies and gentlemen, please make welcome Dr. Kerry Chand, who will present the topic of strategic directions for Hep C elimination in New South Wales, and will also be officially launching the Hep C Elimination in New South Wales Monitoring and Evaluation Report.
Thank you very much. And before I start, I would like to acknowledge the traditional custodians of the land on which I'm standing, the Bidjigal people of the Eora Nation, and pay my respect to elders past, present, and emerging, and acknowledge any Aboriginal people with us here today. And I think Colette's justice health data and Greg's data show that there's still more to do in terms of reducing inequity and improving access. So I would like to acknowledge those people here today who have been impacted by hepatitis C over the years and extend a warm welcome to you. I would also like to say thank you to everyone who has worked so hard. I want to acknowledge Colette's comments that much of the testing impact in justice was because they were diverted to vaccine rollout in prisons, antiviral distribution, managing COVID outbreaks. And I just want to acknowledge the work that everyone in this room did. Even though it was a dip during those years, we actually maintained a lot of those critical services, and it was due to the innovation and collaboration and partnership. So just very much thank you. New South Wales has had a strong record in addressing hepatitis C, and for those that probably have worked with me as a colleague know that this has been a particular passion. And I'm absolutely committed to eliminating hepatitis C because I think that Australia is so well positioned to do it. And we're probably in a unique position given the funding and access requirements. And although we have stigma and discrimination, we still have better settings than many countries around the world to provide equitable access. So since 2016, we've treated over 35,000 people, which reflects the hard work of our sector and shows our ability to scale up new models of care and adapt to a changing landscape. However, as Greg's shown us, many people are living with hepatitis C in New South Wales, and I think the report showed that particularly a focus on some of our rural and regional areas is really required in the year ahead. But I want to acknowledge that support from all stakeholders is needed to reach priority populations, including people who inject drugs, Aboriginal communities, and people residing in rural regional settings. So it's important that we actually embed hepatitis C testing as part of holistic care in alcohol and other drugs, mental health services, Aboriginal controlled health services, and our other settings that might provide care to vulnerable people. And just sort of reflecting in some discussions before I even came in today, it highlighted the sort of analogy that as we get down to the pointy end of achieving elimination in more vulnerable groups, we're actually going to have to work even harder, more innovatively and more holistically than we've ever done. And that's going to mean that we're going to have to accept that for some, we need to provide that multidisciplinary integrated care, those supports and social supports, to even allow them to have that room and space to contemplate treatment. And so that's going to require that particular engagement cross-sectorally across our services that reach vulnerable people, but also to work in that whole of government way. I think it's been great to see the innovation that we've approached new testing methods. I want to congratulate, the Kirby for some of their innovations in point of care. I want to congratulate the innovation around dried blood spot. So for everyone in the room, we are going through a process where we did a bit of a scoping and we thought, do we need dried blood spot testing as part of the mix? And the wisdom was, yes, we do. It serves a particular purpose. And so we are in the process of going through that TGA approval process so that health pathology, New South Wales will be able to conduct the dried blood spot test as a licensed test. That will mean that it's integrated with our pathology reporting systems, and the turnaround times and throughput will be sustained and predictable. I just want to acknowledge the work that had been done by SIDPATH in helping us oversee the creation of the dried blood spot and the lot of blood, sweat and tears that went behind its rollout. But now we have to move it from an ethics framework, which provides some constraints to its use, to a validated test, because we have always had quite a strong degree of confidence in that test. I also just want to call out the collaboration in getting that data. Amazing effort to get paired samples in our prison system, in both the public prison system, a few of our clinics, but a big call out to the efforts in Mid-North Coast, and a big call out to Jenny Heslop up there, who without her drive and passion, I think we reached high score of an amazing number of samples. But also in the course of that validation, really embedded dried blood spot testing within the private system, and so actually strengthened our treatment across into the private. So in order to reach our targets, I think we also, a part of this engagement today is just reflecting on what we need to do. But some of our reflections are, we still need to scale up testing in priority populations and connect them to care. And we're seeing that there's still more room to go in the prisons. And we see the prison setting as a section where yield is quite high. We understand the challenges, Collette, but we're going to really feel that justice is going to keep doing a lot of the heavy lifting. So we're here to help, but no pressure. But yeah. We are also going to focus on those services, like, again, we think our drug and alcohol services, who have made great inroads into embedding blood-borne virus screening, can do more. But as I said, working in more holistic ways. Obviously, the data Greg's presented means that we really have to rethink our regional and remote services, look at how we can better support our Aboriginal community-controlled services who provide significant access to populations in rural regional areas, as well as our GPs and other primary care providers. We know we also need to work closely with our culturally and linguistically diverse communities, and we know patterns of migration are changing. We need to work with our Aboriginal communities. So in terms of moving to the more formal parts of launching the report, it is my great pleasure to officially launch the monitoring report. I did say that I read it in depth and I've got a number of questions about the what ifs and what does this mean. And I think it'll also be important that we capture some of the contextualizations that, Collette said that some of the decline in testing rates were really because of redirections of activity during those pandemic years. But the report reflects, pleasingly, the great progress we've made in key settings and priority populations, and identifies areas where we need to narrow our focus. And I think I've reflected on some of those from my take of the review of the report. We need, as I said, to integrate hepatitis C care into our key settings. And we need to look at all opportunities to embed that. And this comment around hepatitis C testing is paralleled with our desire to test for other things. And so when we're going into these settings, although we'll bring some view of hepatitis C, I think what we're learning is for these settings, we need to take a holistic view where we're concerned around syphilis, we're concerned around HIV, we're concerned around hepatitis C, and for some communities, hepatitis B. And so actually thinking more holistically about the integrated care that we need to embed as business as usual in some of these services that we know are reaching high-risk populations day in, day out. And most importantly, secure linkage to care. And as I said, linkage to care is going to need to be incredibly flexible models where we learn collectively as we go on that journey around what it takes to support people into a better health is my aim, but obviously a subcomponent of that will be engaging hepatitis C treatment and achieving a cure. I was sort of saddened to see the additional burden of advanced liver disease in rural populations. So I think that's really on the to-do list of us to reach out and look at how we can do that better. Really to unpack what are some of the barriers to that. Are they referral pathways? Are they access to testing? I think more work needs to be done there. Also, the report shows that we continue to need to reflect on reinfections, but I'm probably going to take Greg's more positive view that the only way we're picking up reinfections is that we've got that strong engagement in testing and treatment. And I think that we have to characterize reinfections as a sort of more, yes, whilst we want to avoid reinfections, we also need to see the reality that we will always have some reinfections and not stigmatize or discriminate or see that as a negative outcome. So it's finding that sweet spot in our narrative around reinfections, I think, is going to be an important thing. So before I wrap up, I want to say thank you to the Kirby and those stakeholders involved in developing this report and advocating for the needs of people with viral hepatitis. And I'm sorry, I have got a number of red points there that I do want to clarify afterwards. So we might have a meeting. And it's critical that we have this key information about how we're tracking elimination in New South Wales and how we need to narrow our efforts to get closer to our goals. And I think that we've learned a lot about the need to really unpack and really dig down deeper. And although we've presented a lot of data, probably an increased emphasis on some of the behavioural insights, the drivers and motivation for testing, that's going to probably be a challenge for us to collect that as we get to this really pointy end of reducing and driving that to reach those targets. For me, this remains one of my priority areas. And so I really am very open to hear at any times new and novel ways in which we can do it. But I think we should be incredibly proud of what we've achieved to date. So thank you everyone in the room. And it really reflects the openness, collaboration, and the mutual respect that everyone has for working together. The other bit I want to talk about is discrimination and stigma. That comes up in all our reports around why people don't access care. And for me, I really need to think we all have a role as health professionals in calling it out. So can I just really indicate that anytime people encounter discrimination in our healthcare system, we do need to call it out, we need to elevate it, and we need to unpack it. We're not going to address this if we keep on, hearing about discrimination, and stigma and how that's impacted, because I think we need to do more work at educating healthcare workers about how they use language, how they use words, how they engage. That has an impact on the person. And I'm hopeful that there's a middle group that actually are just unaware. Now, that's probably my glass half full indication, but whether there's a middle group that just doesn't realise that what the power of language, the power of raising something inappropriately, not taking the time to explain why they've asked the question, and why that is necessary for medical care or understanding treatment, as opposed to just having it as a drop, dropping it there. So again, this is an area that the ministry really wants to do work in, but to do that, I think we need to have a culture of calling it out, but really understanding what that looks like and what's more important. What are the effective interventions we can put in place? Because you're talking about it from a Hep C lens. I hear it from a HIV lens. I hear it from a syphilis lens. I hear it from a not willing to engage in drug and alcohol. I hear it from many different groups. So this is an underpinning theme that we need to address in our healthcare system. Thank you.
Thank you very much, Kerry. Thank you, Kerry. And this is it, folks. This is the time to throw to you, and it's questions from the floor. We have 2 microphones set up, one on either side of the room. So this is your opportunity to quiz interrogate, challenge, question, all of those exciting things. You've had an hour. You've had lots of time to think. So don't be shy, jump on up, and if you can give us your name and who in particular your question might be directed to, and we'll get them up here on the lectern to give you an answer. And there's no one behind, there's no one online. So yes, come on up, come on, yeah, that'll encourage people to come up, yeah. It'll embarrass them, make them ask questions. Yes. Yep.
Yeah,
Thank you.
My name's Emma. I'm with with Greg, his program. I'm an Aboriginal research officer. I just have two questions. So I wanted to know, is there, with the Justice Health Consumer Advisory Group, is there direct collaboration with the Indigenous workforce in Justice Health?
Yeah, there is. It's only in the very early inception stage. We've only just developed our terms of reference, but that's absolutely in there. So we'll be using internal, but also external. So yeah, it's really key for us.
Okay. Yeah. Is that through like Grantley, Creighton?
Grantley's involved, but it's through the Pop Health team who are setting it up. We've got a consumer engagement officer with a specific project, but Grantley's on there too.
Okay, perfect. And then second question. Actually, no, you just answered it. Answered my second question.
That was easy.
The price of one.
Yeah,
Well
like
done.
that.
Kerry, looks like you might be able to ask some questions of Greg.
It's all right. They're just contextual questions, because I think one of the issues for us that we've got to grapple with is what is the surveillance mechanism we need in the future, because we just had some really interesting discussions that a few of the private pathology companies are, for instance, doing reflexive testing. So that means that will be a really interesting data at a community level, and we can use that. So for me, I'm interested in, focusing down on RNA positive, and if we know those companies reliably do that, then we can discard the antibody positives and really focus our efforts on the RNA positive. So for me, I'm interested in the sort of surveillance systems. We're reflecting on, Miriam's done the SearchX initiative, how frequently we would need to do that. So for me, that's probably something that I'd really love to discuss with the, Kirby, because funding is always limited, and we need to invest in service delivery as well. And increasingly, if we've got some ability to log testing results more systematically through Justice, can we really get some of the data, even from some of the, in a more nuanced way? New South Wales Health is moving to a single digital patient record, which is so exciting. It's going to take us a few years to get there. But also a single laboratory information management system. We currently have 3. So you can imagine that presents really beautiful for any of the data linkage people in the room. You can go, oh my God, we don't have to link across 8 EMRs, 3 LIMS systems, and the ability to potentially use that. So there's a whole process now. And so really exciting times. So for me, some of the questions related to surveillance.
Maybe just to respond to that, I think, we've got pretty good surveillance systems, I think, in comparison to most jurisdictions. So there's a real positive there. What's interesting is that we've got really great surveillance amongst high-risk populations. So if you look at the NSP survey, look at Ethos Engage, and now look at OzHep sort of in the prison sort of setting. And it's pretty remarkable. The NSP survey is telling us that we've gone from half the people having active infection to 10%. I mean, that is an incredible reduction in 7 years. Now, is that reflective of the broader population? Our mathematical modelling in terms of the modelled outputs is telling us we've only halved the number of people living with current infection. Have the models got some things wrong? We need to look at that more closely. Is there too much duplicate notifications into the system? I think Miriam's project, Search 3X, through the emergency departments is really crucial because it gets to that broader population. So it's not a high-risk population targeted sort of surveillance. So, I mean, one of my sort of solutions is to expand that type of surveillance to include outer metropolitan, rural areas, so that we know from the preliminary data from search that it looks pretty good in metropolitan Sydney, at least in southwestern metropolitan Sydney. But is that going to be the case across Sydney? Is it going to be the case in Dubbo, in Wagga, in Lismore? So I think they're the sort of questions that we really need to try and answer. And we need to work with the modelling group as well to try and refine some of that modelling to get more sort of, accurate estimates of, the number of people living with Hep C, where they are, who's missing out, et cetera, et cetera. So there's a lot more to do, but
yeah. I
Jason.
mean,
Oh,
sorry,
sorry,
Jason,
sorry.
go.
No,
Sorry.
go ahead, Miriam, because maybe this is related to the search stuff. It might tie together
Yeah.
nicely.
Look, it's been really fantastic to have ministry support to, innovate in this space, and Greg's collaboration to, properly understand the data that we've done in this emergency screening. But the truth is, we were motivated, I was motivated strongly by trying to find those patients who weren't otherwise engaged. And actually, I thought they were potentially the overseas born, for example. The data is incredibly useful for prevalence, but the overall value, when we discuss this, it becomes hard to interpret the cost effectiveness when the numbers get so low. And a lot of the other projects are extremely expensive too, I imagine, and yet, their value is clear. My question is, it can be extremely hard in this environment to understand what things cost and is it worth it. And I suppose that was my reticence for saying, yes, we should roll out emergency screening everywhere, because it's really hard for us to know. And I wonder as well, in ministry, it's kind of hard.
Yeah, so we're not saying that. I'm actually taking a counter view that, I think it's contributed really important data. Now's the time to respond how we put that in the mix and what are the additional data points we need and what we can get just seamlessly. Because if we systematize dried blood spots, say, in all our drug and alcohol services, and for every patient that goes through the prison system, we have an absolute census. It gets linked into the pathology data system. We can do everything. It can be linked to the clinical records. We can understand Aboriginality because it draws from that. We can get cultural and linguistic background because it will pull all of the data that we've already pre-existingly got. So the question for us is, what else do we need in prisons? And it might be that we invest any scarce money in understanding more qualitative stuff around why people are not, accessing care. So I think we have to continue to refine what data we need, because the pie is the pie, and what surveillance. And I love data. I'm someone who truly loves data, but I don't like data that doesn't add value. And we always have to make these choices around where we spend money to get that. So I think they're the conversations we need ahead. And I'm not saying they're now, but some of this functionality will come online over 2 years. We've got good relations with our private pathology providers, and we worked closely with them through the pandemic. We've always had good relations, but we've even strengthened that. So the ability for us to get data from them to the ministry to supplement our data will be highly likely. And that may be the cheapest way, even if we have to pay a small amount of administrative time for them to analyse that data. At least it gives us population. One of the learnings from also the HIV approach is that we do need to recognise a lot of testing goes on in general practice. And that's what we actually wanted in HIV, because as we saw the switch from most of our diagnosis were being made in our S100s and our sexual health clinics to enabling general, pushing that message, it's a primary care sort of thing. And I think now, I haven't seen the latest, I can't remember the latest data, but I know we always shifted it to majority of our diagnoses are done by GPs. And that's why we put the support program in, because often GPs were finding occasional cases of HIV. So again, looking at those private practices. So I'm with you, Miriam. I know funding's incredibly tight for districts, and we have to be appropriate.
Jason.
Great. Jason Grebley from Kirby Institute. So first of all, great presentations by all of you. So thanks. My first question's for Carrie, and maybe it's actually nicely tagging into that. So it's fantastic you mentioned around the private labs taking on reflex RNA testing, which is great. And I know, for example, Chris has been working and the team and you know yourselves have been working really hard to kind of crack that problem of the reflex testing. I think it's now solved. I think there's ways to do it in terms of
Can't say that yet. We've got a meeting. When is it?
Oh, sorry. I wasn't going to say
weeks.
I wasn't going that was actually going to be my question to you. The private labs have solved it, and there's ways to get around the workflow. And I was just curious as to what you can talk about. Not, I don't want to put you on the spot, but how are things going around the public labs? And do you think that there's a potential around reflex testing to happen?
We're strongly engaging very soon.
Good.
Sorry, 2 weeks. 2 weeks to talk about it. And look, I think the will is there.
Awesome.
We just really need to understand the barriers. It might be the particular tests they've got or the particular flows. Like, I think we need to be conscious that laboratory quality assurance is set up to make sure tests can be relied upon and trusted. So we need to respect that, but just understand if there are new ways in which we can move. So we're going to have a discussion to really understand the nuts and bolts of that. What's the privates doing? But the fact that the privates have moved perhaps gives us some, at least, options. It may take a while, but we're really committed to this because we see this as just so critical. And I know when we were looking at it, it's a smaller proportion of testings, but certainly in the interim, we can also look for those hospitalised inpatients having just almost standing pathology orders, which is slightly different because if they're in inpatient, the venipuncture nurse can then just go and take it the next day and a form gets written. So we can look at the workarounds for some groups of our patients, but then look at ultimately whether we can do the reflex testing.
That's great. And just so you know, in the background, in complement to this, is that we've just been revising the national testing policy with ASHM and the federal government. So that's all going to provide some support around this as well. But just thanks so much for your efforts around that, because it's really great. And the team and your team, because it's really appreciated.
Just to add to the discussion, why this is so important is that my sort of hypothesis is that there's an increasing proportion of the supposedly new hepatitis C diagnoses based on antibody testing positivity that are either duplicate notifications or are false positives, because we're doing an enormous number of sort of tests. So if we can reflex every antibody positive to RNA, so that proportion of the antibody positive to RNA is a key sort of element that we can track and sort of try and unpack. And that feeds back into the modeling estimates, and it's really, really useful. So just to support the work that you're doing. That out.
And thanks to the New South Wales Health team for working on it. My second question is to Greg. If there's no other, I just don't see anybody else.
You're allowed to ask a question of the.
No, it's not. But I'm just curious as your thoughts, Greg, around the late diagnosis stuff. And I know that the data is like hot off the press. So maybe I won't ask you if you know where they're happening. But what do you think moving forward is sort of the strategies of what should be done next? Maybe what are the next steps?
So you haven't read the whole report, Jason. No,
I've been on leave in Bali, Greg.
As Carrie's done, because you would have seen some maps by LHD.
Oh, beautiful.
That are in the report that are really interesting in terms of some of the particularly rural LHDs. Obviously, some have very small numbers of liver failure and liver cancer presentations, but there are some LHDs, I won't name them, who have pretty reasonable numbers and relatively high proportions of people that are late diagnosed. So there's a few sort of areas to target. The other thing that we're doing that's not in the report, but we'll have that data very soon, is looking at another sort of category of missed opportunity, which is late therapeutic intervention. So we're looking at people that develop liver failure, liver cancer, and haven't been treated for up until 2 years prior to that. Now, obviously that includes the late diagnoses, but there'll be a bunch of other people being diagnosed for years, but haven't taken up the opportunity for effective intervention. And we'll look at that by LHD. So I think there are two key sort of elements we can continue to monitor really closely and help to target some of these sort of specific areas of the interventions. Yeah.
That's amazing. That'll be super helpful.
Jason, the numbers are quite small in some of the areas, and so it does lend itself to clinical case audit and looking at missed opportunities or the context, because ultimately, if we're going to change it, is it because there's a lack of clear pathway in rural regional? And that should not be the case, because New South Wales Health runs a very linked system. And so access to specialists, with telemedicine and some of the initiatives that really were turbocharged through COVID means that a lot of our rural and regional areas get, for instance, ICU support. They get drug and alcohol support. They get psychiatric counselling, speech pathology. Some of the concepts of, linking in for telemedicine services. Again, we've learnt around the importance of having like nurses or Aboriginal health workers sit with the patient as part of telemedicine, or the primary care practitioner, so different models. So we really need to understand what the reasons are for those. And it may be that they're actually fixable going forward, but also some of the systems may have actually been put in place, because obviously this reflects a backward looking.
Sure.
But just to check that we've got those settings in place. But I think we need to raise some more hypotheses of what it looks like. And obviously a particular Aboriginal focus, is it because of access to testing, treatment, or barriers to transport, moving, those barriers. And again, how can we work in partnership with our Aboriginal community health services, again, if it's an issue of access to specialists in a safe, culturally appropriate setting.
Awesome. Thank you both.
Thank you. We're into the closing. Yes, fantastic.
I'm Miranda. I'm a medical student. I'll be conducting my fourth year research project next year under the supervision of Marianne and Greg. I just had a question regarding the touching on screening uptake for Hep C, and particularly those last high-risk groups. What's actually being done to identify those barriers and address them at the moment?
I mean, Collette can talk about the barriers in prison, but I think, they're structural barriers, they don't like needles and things like that. And people that inject drugs also don't have great venous access and don't like people messing with their veins. And so that's why, point of testing and some of the dry blood spots being much more amenable to those. Often it's functional areas that, our services have got a particular focus, like even the issues in terms of the risk that patients are being managed in remand in prison settings. They're really worried about mental health screening and safety risk, So it's also acknowledging that the services we provide, so we've always got to provide it seamlessly, understanding the role with the dry blood spot. It's good because peers can help, and health workers that are not, nurses and other things. So it gives a broader access. So we know that there's multiple barriers in multiple sites, and I think we're trying to use a suite of different testing, but some of it is changing the culture, and selling the issue is important. We've tried lots of initiatives in our drug and alcohol services, and I think we're getting traction now, but there's still variability in that. And so we've got to push. It's God, if this was just easy, we said, do screening, go forth. But it'd be really, there are many, but there's probably deep and rich understanding of everyone in this room, in all settings, but we still need to learn more. There's probably additional barriers that we'll unpack as we go through to the next group. But Greg, did you want to say anything? Because your studies.
No, sorry, I think Kerry sort of highlighted that we just need to keep innovating. And I think Australia, has been really at the forefront of innovation, both in terms of therapeutic strategies and diagnostic sort of modalities. And we do need to keep pushing the envelope. I mean, one sort of example of that innovation is that, it's interesting that Collette mentioned the proportion of people in correctional settings that are in remand. And we've got a study that Marion Martinello is sort of leading, about to sort of kick off again. It's sort of COVID got in the way, but we're looking at a 4-week treatment strategy. We're combining Mavorite, which is normally given for 8 weeks, with sofosbuvir, so that'll be a 4-week sort of strategy. We think it's got a very good chance of being highly curative if effective, then implementing that in settings where maybe you've got an individual there for 4 or 5 weeks and you really want to get the treatment done. I mean, so that's an example of what we can continue to do on the innovation front. So we just shouldn't sort of rest on our laurels, should keep sort of pushing the envelope. It's really, really crucial.
Thank you.
No more? Oh. Yep, last one.
Hi, sorry.
Last two.
Oh, sorry.
Last two.
I haven't got a question. I just wanted to share a little story. So the chat today and at our meeting last week around strategic planning around hepatitis C was all about, you know, the statistics but in the real world. So I just wanted to share a little story. So I'm a nurse practitioner at RPA, and the other day, just after I'd come from the meeting and we'd been told about, you know, the longer delay or taking longer or a higher proportion of people in the region in rural settings having delays in getting diagnosed and then delays in getting treatment. And I took a call from a GP in a outer New South Wales regional rural area. And they had a patient sitting in the waiting room in their small clinic in the country, and they had received their blood test results, and they were trying to interpret the blood test results, and they were about hepatitis C and hepatitis B. So they decided to call up Hepatitis New South Wales, and they called the info line, and they got a very, very helpful person on the info line that day who got so far and then said, you need to talk to someone else. And so they handed out my number. And so within 2 minutes, I had 2 phones going saying, call me, and the other one with a random number from the country. And it was the GP on the phone saying, look, I've been given your number and I have this patient in the waiting room and I just need to know what to do with all of this. And so we talked through the results. Clearly, he thought the patient might have acute hepatitis. The patient didn't. The patient had chronic hepatitis C. And he said, oh, well, I'm going to have to refer him and I'm going on leave tomorrow for a month. And I said, no, you're not. So 67-year-old male sitting in the waiting room with his wife, brought them in, had a lovely team consult with me down the phone. And the patient had a local pharmacy that he was already on many other different meds, none of which interacted, and was able to get his pills, his hepatitis C treatment started. So I just wanted to give the little real world situation and the teamwork that really helped that particular person. Yeah.
And I think that really highlights the fact that we've got to look at where GPs call to do that, make it easy and make it a one-stop shop. We've been trying to do that because obviously even the public health unit in Broken Hill and Dubbo does not have a strong clinical presence. We've set up the SHIL helpline, but we also can't give doctors multiple numbers because they don't navigate them. So I suppose we just that's a really good point of where is the navigation system within it and what are we going to set up as if you need help, call me sort of service. But in doing that, don't disempower usual referral rates, because we've learned in other settings, if you set up sometimes statewide services, it doesn't grow the capability for escalation locally as well. So we've got this tension more for our hospital system services. So that's a really good example of how we've got to unpack. But well done. That was amazing. That was amazing.
Thank you. And our very last question.
I should have stood up earlier. Marianne, Kirby, Prince of Wales, Justice Health. I had a couple of questions, but I'll just make it one. And this is about equitable healthcare again, but going back to the beginning and harm reduction. So Collette, Kerry, what can we do to get needle and syringe programs or improved harm reduction in prisons? If we're going to eliminate Hep C there, we can potentially try and test and treat our way out, but if we don't prevent people getting hepatitis C.
Yeah, look, Marianne, it's very difficult.
I'm asking to be.
And look, it is a tension. I mean, I think, at the end of the day, we've got a huge workforce of corrective services and their job security. And obviously they're very worried about needles and syringes and my argument is, but there's already needles in there because they're getting reinfected. So, it's a very delicate balance. And I think it's I think it has to be baby steps. I think there's been a significant discussion going on around changing the disinfectant, and corrective services have never been open to that before, but they are recognizing that this is an issue and that we make it safer for them. I also think with needle syringe programs, there's multiple around the world. Some of them are good and some of them aren't. The evidence is pretty ropey. I would love to be running a pilot because we need the evidence. I don't think we can have a free for all, because safety is an issue, and where we're all advocates, and particularly me in social justice and justice health, there's some people in there who are not nice people. And we have to acknowledge that too. So it's a fine balance. I hope in my lifetime we get there to at least get a pilot, but we'll wait and see. It's obviously it's a big discussion, but I'll let the ministry.
No, that's right.
What can we do as healthcare practitioners and then at the policy level?
Look, to be perfectly frank, I think you need to look to the experience, and I'd be asking this of ACT. ACT's had a platform of allowing NSP in prison and has not managed to get there. As a public health practitioner, I am open to all evidence-based interventions, but they need to happen within a policy frame that's implementable. And so at the moment, my absolute passion is to get the dried blood spot universally in there, follow up with everyone in prison and treating it, and getting immediate, commencement of antivirals, the work that Greg's, the proposal that you all think's interesting as well, because one of the things is if we can actually decrease the viral load substantially in our prisons, and I think Southern was telling me South Australia's got very, very low,
very low prison population.
Low prison population. Oh, well, anyway, it doesn't matter. We can gloss over that bit, and we can still aim to get it down to be very low. But I mean, I think the evidence would be if we can really reduce viral load, which is the whole premise of it, we can do it. But those other discussions probably are really in a whole of government. But I think there'd be learnings from other states, particularly ACT, that's attempted to put this in place.
Just one other thing that we need to do is, with the second round of the OzHep surveillance system being rolled out soon, it'll be really interesting to see whether there's been a change in risk behaviours since the expansion of OAT and depot-buprenorphine. Hopefully there will have been some, but I think that's something we really need to keep sort of monitoring closely.
Great. And on that note, we'll wrap up. Can you please thank our fantastic presenters today, Greg Dorr, Collete McGrath, Kerry Chant.
Just finally, really like to thank Sam and Rata and everyone else who sort of put the seminar together. It's been a great afternoon, but obviously a lot of planning goes into it. So thanks very much.
Thank you, Greg, for stealing my thunder. Ladies and gentlemen, thank you very much. Please have a wonderful afternoon.